All right, it's the top of the hour. Let's get going. Thank you all for joining us today. I'm going to get started with our introductions and housekeeping while we let people trickle in for the webinar. My name is Cheryl Collins. I'm the Senior Marketing Manager for Metrex. We're happy to bring you this professional education webinar in conjunction with APIC. Please note that the CE credit will be provided by Metrex, not APIC, and I'll share instructions on how to claim your CE after the webinar. This presentation is being recorded. The recording, along with the presentation slides, will be made available to you post-webinar. And we've reserved time for Q&A at the end of our session. If you'd like to submit a question to be answered, please use Zoom's Q&A feature. If you experience technical issues, please use the chat to alert me. I'm monitoring both the chat and the Q&A. For questions for our presenters, please use the Q&A box, not the chat. That's all for the housekeeping. Now, please allow me to share a little bit about Metrex before I turn it over to our presenters. Metrex is all about infection prevention. We believe no one should ever have to fight for their health over an infection they didn't have when they entered a healthcare facility. And our vision is a world without any preventable healthcare-associated infections, or HAIs. Metrex has made it our company mission to support healthcare professionals in the fight against HAIs, so your time, energy, focus can remain on the most important thing, getting the patient better. Next slide, please. Metrex is best known for CaviWipes disinfecting wipes, but our portfolio includes instrument reprocessing solutions, high-level disinfectants, and hand hygiene products too. We are coming to the end of our 40th anniversary celebration and appreciate you all for being part of it. If you have any questions about our products and services, you're welcome to reach out to me at metrexmarketing@metrex.com or visit our website at metrex.com. And next, it is my pleasure to introduce our two speakers for today's webinar. First, we have Jane Gabalski. Jane has been with Metrex since 2018. In her role as clinical sales specialist, she works closely with infection preventionists during product onboarding. She supports sales teams and provides product training. She has a Bachelor's of Science in Nursing from Niagara University, and her experience as a registered nurse includes medical surgical nursing, case management, and discharge planning. And of course, Sharon Wardford. Sharon has worked in healthcare since 1985 with over 15 years of experience as an IP. She's an independent consultant, a member of the editorial advisory board of ICT Magazine, and a clinical editor for the APIC text. In 2023, Sharon was recognized by Infection Control Today as the Educator of the Year. She has a BS in Biology and Medical Technology and an MS in Clinical Microbiology. She is board certified in infection control and is an APIC fellow as well. Sharon and Jane, thank you for being here today to share your knowledge with us, and I'll turn the presentation over to you. Thank you.
Okay, great. Thanks, Cheryl. Hi, thank you for joining us for Infection Prevention Basics. Next slide, Jane. Okay, today we'll describe IP best practices. We'll talk about emerging technologies and updated standards in infection prevention. We'll explain how checklists, redundancy, and debriefing can improve safety and compliance in the workplace. And we'll discuss barriers to adhering to the manufacturer's instructions for use, those IFUs. Next. Okay, let's start by looking back at the basics. Infection prevention has evolved over decades, but our most powerful tools really haven't changed. These old lessons, hand hygiene, PPE, and cleaning and disinfection of the environment, remain the core of every infection prevention program. Now, even though these practices are foundational, we continue to see breakdowns in compliance, training, and consistency. The basics are still where many of our biggest risks to our patients and in CMS and accreditation serving findings are found. In this section, we'll walk through these three critical components. We'll look at what makes them timeless, where we still stumble, and why they're more relevant than ever in 2025. So let's start with the one we all know but still struggle with, hand hygiene. Next slide, please. We understand that hand hygiene is the most effective way to prevent the spread of infection. However, even after many years of awareness campaigns, according to the CDC, only about 50% of healthcare workers are consistently practicing it. This means that in any healthcare facility, half of the opportunities to perform hand hygiene are being missed. And these missed chances often occur at the most critical moments, before touching a patient, before performing sterile procedures, or after removing gloves. While we've made progress by improving how we monitor and audit hand hygiene, true success really depends on creating a strong culture and a sense of responsibility. When hand hygiene becomes a natural habit rather than just a checklist task, compliance improves and so does patient safety. The real challenge isn't just knowing what to do, it's making sure we do it every single time, especially during busy, hurried, or distracting moments. Leadership support, peer reminders, and environmental cues can make a huge difference. Ultimately, as simple as it may sound, hand hygiene remains the cornerstone of infection prevention and the key to building reliable safety practices. Next. Now, the issue isn't always knowledge, it's behavior. Staff know how to perform hand hygiene, but time, pressure, glove use, workflow, interruptions, all of these things get in the way of doing what they know is right. So let's think about some of the most common pitfalls. How about sanitizing over gloves instead of removing the gloves, then sanitizing? Gloves are worn for two reasons. They provide a protective barrier to prevent contamination of hands, and they reduce the likelihood that microorganisms present on hands will be transmitted to the patient during invasive and other patient care procedures. The 2022 SHEA IDSA APIC update on glove use had three recommendations. First, teach staff about the risk for self or environmental contamination. Second, teach proper doffing of gloves. And third, validate that your staff can remove their gloves safely. Following these recommendations can help make sure gloves are used appropriately to reduce hand and environmental contamination. Technique and timing of hand hygiene matter. The CDC reminds us that performing hand hygiene for less than those 20 seconds or missing certain surfaces on the hands can make the effort ineffective. The thumbs, the wrists, the back of the hands, the spaces between fingers, and the fingertips are the most commonly missed areas. Now let's look at the 5 key moments when healthcare workers should perform hand hygiene to prevent the spread of infections. These are before touching a patient. This prevents the transfer of organisms from the healthcare worker's hands to the patient. The second is before clean aseptic procedures. This protects the patient from contamination during procedures such as inserting catheters or administering injections. Third, after exposure to body fluids. This removes contamination that may have been acquired during contact with bodily fluids, such as blood, mucus, or vomit. The fourth is after touching a patient. This prevents the spread of organisms from the patient to the healthcare worker or other surfaces. And last, after touching patient surroundings. This removes contamination that may have been present on objects in the patient's environment, such as furniture or medical equipment. Because healthcare workers generally underestimate the role of environmental surfaces in the transmission of infection, compliance with hand hygiene following contact with the environment is generally lower than that following direct patient contact. To reduce the risk of transmission, healthcare workers need to be aware of the need to perform hand hygiene when performing specific tasks or events. Next, let's talk about PPE, because even the best hand hygiene can't protect us if our barriers are used incorrectly. PPE serves as our personal safety net, but it only functions efficiently and effectively when used properly. In audits and outbreak investigations, the same mistakes are consistently observed. Improper donning and doffing procedures, neglecting eye protection, and inconsistent use among staff and shifts. During routine care, staff always underestimate exposure risks. For instance, eye protection is one of the most frequently missed elements in both standard and droplet precautions. Now, the risk isn't theoretical. Splashes and sprays occur even in non-ICU settings. What's important to reinforce is when PPE is required. Standard precautions, anytime there's exposure to blood or body fluids. Transmission-based precautions, for contact, droplet, and airborne spread. If you're unclear on what PPE to use, go to the CDC website for Appendix A, type and duration of precautions recommended for selected infections and conditions. We also want to wear our PPE during surgical in procedural areas where sterile fields are maintained, hazardous drug or waste, especially under OSHA NIOSH guidelines. Errors like sanitizing over gloves, reusing gowns, or skipping eye protection can lead to self-contamination and transmission to others. Consistency, not just compliance, is key, especially when surveyors are present. Next slide. So what happens when PPE isn't used correctly? One of the most common issues observed involves improper donning and doffing. A single mistake, like improperly removing gloves or touching the front of the mask, can lead to self-contamination. In outbreak investigations, these small errors are often where transmission occurs. Now, eye protection remains one of the most skipped PPE items, even during standard precautions. COVID-19 taught us how easily droplets and splashes can reach mucous membranes, yet compliance still varies. Gloves and gowns are other weak spots. Sanitizing over gloves or wearing that same pair between patient rooms, that undermines everything we teach about cross-contamination. Gowns left untied or reused between patients create direct exposure risks. Did you know that PPE compliance often decreases significantly when staff feel they're not being observed? This shows us that the challenge isn't about knowledge, it's about accountability, culture, and habit. So our job as infection preventionists is to make PPE a safety reflex, not just a checklist. Leadership modeling, peer reminders, and quick just-in-time coaching are the best tools for building that culture. So from PPE, we'll shift to environmental cleaning and disinfection, another area where the fundamentals matter just as much as they did 30 years ago. Next. So environmental cleaning and disinfection is the third pillar of infection prevention. It's not glamorous, but it is crucial. Cleaning and disinfection are two distinct processes. Cleaning doesn't kill microorganisms, but it significantly reduces their numbers, making surfaces safer to handle and use. Now, cleaning is a critical step before disinfection because those disinfectants cannot effectively kill microorganisms if they're hidden by debris. And effective cleaning should always involve mechanical action, that's scrubbing or elbow grease. This physical effort is just as important, if not more so, than any antimicrobial effect of the disinfectant that follows. If bioburden or organic material is still present on a surface, even the best disinfectant product won't work. Now, disinfection, that's a separate process from cleaning. Disinfection involves killing a high percentage of microorganisms or rendering them incapable of reproducing. Contact time, also called dwell time, determines if the disinfectant kills the target pathogens. Both terms refer to the amount of time a disinfectant must remain visibly wet on the surface to be effective. Now, if that surface dries before the stated contact time, its effectiveness drops significantly. And that's one of the most common and costly errors observed during cleaning observations. Now, we focus cleaning and disinfection mainly on high-touch surfaces like bed rails, IV pumps, keyboards, and call buttons. These are common transmission points, especially when turnover times are tight. These high-touch surfaces in patient rooms often receive extra attention, while other areas remain highly contaminated due to inadequate or inconsistent cleaning. However, one thing to remember is that contamination isn't limited to surfaces frequently handled by patient or staff. Toilets, sinks, and countertops, while touched less often, can have even higher contamination rates than bed rails. Just because a surface is less frequently touched doesn't mean it poses less of a risk. The combination of frequent contact and high contamination creates an opportunity for cross-contamination, ultimately increasing the risk of infections. Next. So when it comes to disinfectants, the EPA is the ultimate source of truth. Every product used in healthcare for environmental disinfection must be EPA registered, meaning it's been tested, reviewed, and approved for efficacy against specific microorganisms and under specific conditions. Always verify that the product you're using is EPA registered and approved for the organisms of concern. For example, C. diff spores need a product with a sporicidal claim. Now, it's also critical to remember that the product label is the law. And that's not just a slogan, it's a regulatory requirement under the Federal Insecticide, Fungicide, and Rodenticide Act. Disinfectants are considered insecticides. Now, if a label says a disinfectant needs a 5-minute contact time, or that it's effective against Staphylococcus aureus, but not C. diff, then that's exactly how it must be used. And if you don't already know, the EPA maintains several searchable lists of registered disinfectants for healthcare use. For example, List K is for products effective against C. diff spores. List N is for products effective against emerging viral pathogens like SARS-CoV-2. And List Q is for products effective against Candida auris. And I recommend bookmarking this site. It's also where you can verify product registration numbers, review dwell times, and confirm that your disinfectant is appropriate for the pathogen you're targeting. It's an essential resource for infection prevention, EVS, and supply chain teams alike. Let's look what happens when environmental cleaning and disinfection practices fall short. Next slide, please. Okay. These are some of the pitfalls that can undo even the most diligent cleaning and disinfection efforts. Using the wrong product, like quats for C. diff spores, is ineffective and can contribute to outbreaks. Skipping the cleaning step entirely, so soil bioburden is left behind, protecting pathogens from disinfectants. Insufficient contact time. If the surface dries before the stated contact time, the disinfectant's effectiveness drops significantly. And sometimes you'll see this with high alcohol disinfectant products. Reusing wipes between surfaces is another common mistake. It actually spreads contamination instead of removing it. And finally, missing high-touch, high-contamination surfaces. These are the points of repeated contact that drive environmental transmission. Consistent education, audit feedback, and interdisciplinary partnerships with EVS teams makes a big difference here. But disinfection isn't just environmental services responsibility. It's a patient safety practice shared across all disciplines. So why does this all matter? Next slide, please. These three fundamental practices are the foundation of infective prevention. Every outbreak investigation, citation, and cluster can almost always be traced back to a failure in these essential practices. Even as we adopt new technologies and smarter systems, these basics remain crucial for patient safety. Staff need more than just annual refreshers. They require ongoing reinforcement, clear visibility of outcomes, and strong leadership support. Our job as IPs is to bring these fundamentals back into focus, connecting the dots between compliance, culture, and results. Next slide, please. This next section, Something New, focuses on how infection prevention continues to evolve. Technology, automation, and updated standards are reshaping daily practices, but they also introduce new challenges that require careful implementation. Next slide, please. One of the fastest growing innovations in infection prevention is electronic and AI-enabled hand hygiene monitoring systems. These systems are transforming how we measure and manage compliance, moving beyond our clipboard observations, which only capture a small snapshot of behavior, to real-time analytics that address the limitations of traditional observation audits. Electronic monitoring systems can fall into four main categories. There's application-assisted systems where observers use mobile apps to record hand hygiene opportunities in real time. There's camera-assisted systems that rely on video analytics or AI to automatically detect hand hygiene events. There are sensor or dispenser-based systems that use proximity or motion sensors to log when a dispenser is activated. Some even track specific staff with badges. There's also real-time locating systems that combine staff badges, patient zones, and dispenser sensors to create a map of who cleaned their hands and when. The goal of these systems is to make compliance data more continuous and objective. However, it's important to remember that technology is only a tool. It can identify trends, but it can't replace the qualitative insights gained from direct human observation. Successful programs combine these systems with education, feedback, and staff engagement, ensuring the data become actionable rather than punitive. Next slide, please. Some common challenges organizations have faced when implementing these systems are workflow disruption and resistance. Staff often feel that these systems slow them down or interfere with care. The solution? Involve them early. Piloting on a single unit, collecting feedback, and adjusting sensor placement can foster ownership instead of resentment. Accuracy issues. Systems can't yet perfectly distinguish between real and recorded hand hygiene events. Combining automated data with those periodic manual observations provides a more accurate picture of compliance. Privacy and trust. Many employees see constant monitoring as surveillance. This is where transparency is crucial. Make it clear that data are used to identify system issues, not for individual punishment. Cost and resource drain are also real concerns. Start with a single department or maybe a high-risk area to help demonstrate your return on investment. Some organizations have shown reduced infection rates and improved compliance after data-driven coaching began. Then there's data overload. Too many metrics with little of it having any meaning. Simplify the reporting, provide unit-level dashboards with visual feedback to help staff connect the dots between compliance and outcomes. And finally, success depends on culture. Technology works best when combined with human engagement leaders modeling behavior, their peer recognition, and positive reinforcement. We've learned that technology alone won't fix hand hygiene, but when used to support rather than monitor healthcare workers, it can be transformative. So Jane, what are some other evolving technologies?
Hey, thanks, Sharon. Now we're going to move on to talk about what's new in high-level disinfection. The trend in high-level disinfection is towards automation, which eliminates variability that you can see in manual reprocessing. Automated systems will help ensure that every cycle is validated and consistent. Some systems use positive pressure flow to push the high-level disinfectant through all internal channels of the scope, thus increasing compliance as well as consistency. With regards to newer high-level disinfectant chemistries, such as peracetic acid and hydrogen peroxide blends, these chemistries can be faster, more effective, and safer for staff compared to some of the older chemistries like the glutaraldehydes. Automated drying is another advancement which prevents residual moisture that can allow biofilm growth or recontamination of clean scopes. Lastly, there's a growing shift towards sterilization for high-risk devices, such as certain scopes, of course, where technology permits. The goal of these changes is to make high-level disinfection more reliable and less dependent on human performance. Next, we're going to take a look at the most common struggles that organizations face when adopting these new technologies and what strategies are recommended to overcome them. So adopting new HLD technologies offers some real safety and consistency benefits, but they can also bring about some operational challenges. The first of those being cost. These technologies require a significant investment. So when planning, plan for a phased implementation, such as starting small in a high-risk area so that you can demonstrate a return on outbreak prevention, safety, and survey readiness. Second, automation does not replace people. Manual pre-cleaning and inspection are still very important parts of the HLD process, and errors in these steps can weaken the entire system. Ongoing training, audits, and process validation remain essential. Another critical risk area is staff training. Automated systems demand precision, correct connections, proper chemical handling, and troubleshooting skills. So partner with your vendors for training, utilize competency assessments, and reinforce expectations with visual aids and tracers. Cycle validation and documentation are also important. A disconnected channel, one missed MEC test, or incomplete drawing can invalidate your entire high-level disinfection process. So utilize electronic tracking or dashboards. These can help detect issues in real time. Chemical safety improves with newer agents, like we mentioned, the peracetic acid and hydrogen peroxide chemistries, but still require our strict adherence to IFUs, ventilation protocols, and compatibility checks also remain necessary. As organizations transition from high-level disinfection to sterilization for their high-risk scopes, these changes should be phased and carefully planned. Make sure that you have clear communication as well as strong leadership support. Technology enhances reliability, but success depends on trained personnel, validated processes, and engaged leadership. The next new is we're going to talk about what's new with the Joint Commission standards and what they are. So effective July 1st, 2025, the Joint Commission updated the Infection Prevention and Control chapter. The standards now span from IC 040101 to IC 070101, replacing the previous IC 01 through IC 03 format. So let's explore the main points of each new standard. IC 040101 defines the structure of your infection prevention and control program. It mandates qualified leadership, clear roles, staffing based on competency, documented compliance with laws and manufacturers' instructions for use, and current evidence-based guidelines. Standard IC 050101 shifts accountability to the governing body, emphasizing that leadership, not just the infection preventionist, is responsible for ensuring that the program is adequately resourced, supported, and evaluated. This supports CMS's expectation that infection prevention is an organizational and not just a departmental responsibility. ICO 60101 focuses on implementation. Elements of this standard include identifying infection risks and reviewing them at least annually, conducting surveillance, prevention, and control activities, and following defined outbreak procedures when triggered. ICO 70101 centers on preparedness for high consequence infectious diseases or special pathogens. It aligns with emergency management standards and adopts the identify, isolate, inform framework to ensure readiness for pathogens like Ebola, monkeypox, or COVID-19 level events. So looking at this, the numbering and structure may have been revised, but the core message remains. Infection prevention must be risk-based, evidence-driven, and hospital-wide. These new standards make this expectation clear by linking infection prevention directly to governance, readiness, and system reliability. So now that we've reviewed the new standards, this is a good time to take a look at the Joint Commission's infection control hierarchy. This hierarchy guides how we structure our infection control policies to ensure compliance with the Joint Commission standards. By the way, this slide is a great resource to print and have as a ready reference in your workplace. You could even consider hanging it on your bulletin board or your cubicle wall if that works for you. So a little bit of background. The Joint Commission discovered that many organizations were creating policies directly from evidence-based guidelines without verifying that their policies also fulfilled federal, state, or manufacturers' requirements. This ultimately resulted in citations even when the organization believed it was being compliant. To provide clarification, the Joint Commission published this framework, which reminds us that infection prevention policies must start with rules and regulations and then flow downward toward guidelines and professional consensus. So looking at the first three tiers on the slide, federal and state laws, CMS, COPs, and CFCs, and manufacturers' IFUs, these establish the regulatory and legal foundation for our policies. Moving down to evidence-based guidelines and consensus statements, these provide additional details, but remember, they cannot replace compliance with the first three groups. This hierarchy is a valuable tool for your policy reviews, mock surveys, and tracer activities. So the key takeaway here is that nothing has truly changed. The new Joint Commission standards didn't introduce new requirements. They merely reorganized and clarified the existing structure. This was done to improve the layout, but not to alter the core principles. If your organization was compliant before, you'll remain compliant as long as your policies follow the correct hierarchy. And here's a good example. IC02 0201 EP2 has historically been the most cited performance element because it required organizations to reduce the risk of infection associated with medical equipment, devices, and supplies. That requirement continues with the standards now being incorporated throughout IC04 to IC07. By updating your policies and consistently applying the hierarchy, you'll ensure that your infection prevention efforts align with both previous as well as current standards. Now we're going to move on to something borrowed. In this section, we'll explore how infection prevention teams can use high reliability strategies to strengthen compliance, safety, and communication. High reliability industries like aviation, nuclear safety, and surgery share one common characteristic. They all depend on structured, repeatable processes in order to prevent errors. The first tool that we're going to discuss is the checklists. Checklists were originally developed in aviation, and they changed how pilots handle complex tasks. For example, in the 1930s, Boeing introduced the B-17, and this plane was too advanced to fly safely from memory. So pilots started using standardized checklists to document each critical step. This simple step and process significantly reduced crashes and ultimately saved lives. In healthcare, we've adopted the same idea of checklists to reduce reliance on memory and help ensure consistency. Consistencies can be similarly applied to infection prevention. So let's take a look at some examples of checklists we can use. First is for your endoscope reprocessing. You can use checklists to verify that each step in the process, your pre-cleaning, your manual cleaning, and disinfection step are completed before proceeding to the next step. For your daily high-touch cleaning, checklists can be used to make sure every surface receives proper disinfection in order to prevent cross-contamination or cross-transmission. For procedures like line insertions or sterile procedures, you can use a checklist to confirm that all steps in aseptic technique are followed. And these are just a few. I'm sure you can think of many more where checklists could be valuable for your practice as in addition to the ones that you're currently using. So use checklists because they turn human variability into process reliability. They support, but they do not replace critical thinking. Each step in a checklist reminds us that consistency leads to safety. Checklists only work if they're used consistently and if there is a belief that they add value. Now we're going to take a look at some of the common pitfalls of checklists and how we can overcome them. The first of those is checklist fatigue. Over time, staff are given many checklists. Sometimes they're not integrated into the workflow, so they tend to stop paying attention. The solution here is to simplify. Embed your checklist directly into the workflow like EMR prompts or equipment logs so they feel natural as opposed to redundant. Next, we have the classic box checking behavior where staff will fill out forms for compliance rather than function. This can happen when staff don't see feedback or results. So make sure you do some real-time coaching and share outcomes with your staff when auditing for checklist compliance. Another barrier to checklist use is inconsistent use across shifts. In high reliability organizations, they define who owns the process. So assign a lead, someone responsible for verifying completion as well as engaging the teams. Finally, if a checklist is poorly designed and cluttered, it will defeat the purpose. So make your checklist short, clear, color-coded, and logically sequenced. The best checklists provide visual memory aids and are not documentation burdens. When done right, checklists don't just standardize tasks, they help standardize excellence. Moving on, we're going to discuss the concept of redundancy and cross-checking and how teams can create systems where no one single point of failure can cause harm. So redundancy involves creating multiple intentional layers of protection. Think of it as a safety net as opposed to just duplication. High reliability industries don't rely on one single safeguard. Instead, they build layers, each layer capable of catching an error before it causes harm. So we're going to look at four layers. The first layer is the primary process. This layer expects a task to be performed correctly every time. So think about this as your standard operating procedures and your policies. The second layer is independent verification, where another person or a system confirms the step. This prevents one person's oversight from causing a system failure. Third are system safeguards, such as alarms, automated alerts, or built-in controls that flag errors before they reach the patient. Finally, organizational oversight, which includes audits, leadership reviews, and learning from near misses. Together, these layers reduce harm. Redundancy does not mean efficiency, it means reliability. The third concept that we borrowed from high reliability industries is debriefing, a structured reflection that happens after an event, a procedure, or it could even be at the end of a shift. Debriefing is different from auditing or investigating. The goal of debriefing is not to assign blame, but to understand performance in real time while the lessons are still fresh. High reliability organizations like aviation and military teams have long relied on debriefing as a cornerstone of safety. After every mission, flight, or simulation, teams will ask the same three questions. What went well? What could have gone better? And what could we change next time? The same approach applies beautifully to infection prevention. So think about it. After an outbreak investigation, an immediate use sterilization event, or even a standard tracer, teams can pause for a couple minutes and identify what worked and what didn't work. The most powerful benefit of debriefing is team learning. It turns your daily operations and workflow into continuous improvement opportunities, and it lets your staff feel comfortable discussing errors and suggesting improvements without fear of punishment or blame. The key is to shift the focus from who is to blame to what went wrong, so we can learn from our mistakes and prevent them from happening again. We recognize, by doing this, we recognize that processes fail, not just people. Next, we're going to combine these two ideas, redundancy and debriefing, and look at some of the shared challenges of putting them into practice. So in theory, redundancy and debriefing sound ideal, but they do present some challenges when put into practice. The first of those can be a perceived inefficiency. Staff might say, we don't have time for 2 sign-offs, or why another debrief? The strategy is to reframe this as a risk reduction measure as opposed to extra steps. This will save time by catching errors early and avoiding rework or creating repeated events. The next challenge is cultural resistance. Staff may think that redundancy implies that we don't trust them or that debriefing is about assigning blame. Fostering a just culture encourages staff to speak up without fear of punishment, emphasizing learning from our mistakes. When staff see that double checks aim to protect patients as well as staff, buy-in will improve. Another struggle is inconsistent participation. These tools only work when everyone uses them consistently. So make them standard practice, a part of every tracer, procedure, or event review, and eventually they will become routine. Poor follow-through can be another issue. Teams have a great debrief, but then nothing changes. If you close the loop with feedback showing what was changed or improved because of staff input, it will keep staff engaged in the process because they will see that their voice matters. And the last is time pressure. The simplest fix is integration by linking redundancy and debriefing into activities you're already doing, like safety huddles, shift reports, or rounding. If these activities are integrated into the daily workflow, they will start to feel natural as opposed to something that we're adding on to our daily workflow. So these three principles are very important. I just want to take one more look at them and make sure we understand how they help focus on patient safety. Checklists add structure and help reduce reliance on memory. They ensure that every critical step is consistently completed. Redundancy and cross-checking increase system resilience, making sure that no single mistake causes harm. It's about creating multiple layers of defense and verification. And debriefing closes the loop. It turns routine work into an opportunity for learning. Together, these practices help us move beyond mere compliance towards true reliability. They foster a culture where excellence is not left to chance. It's intentionally designed and enhances patient safety. In our final section, something blue, we're going to explore why the basics sometimes fail and what steps we can take when this happens. And we're going to begin with IFU, something that I'm sure is part of our daily challenges. A common challenge in infection prevention is following manufacturers' IFUs or instructions for use. These documents are manufacturer-validated processes that are mandated by the FDA for safety and effectiveness. CMS and the Joint Commission require organizations to follow manufacturers' instructions for all medical equipment, devices, and supplies. These instructions are approved by the FDA before a product is brought to market, and straying from them can undermine the device's or chemicals' intended performance. The reality is that IFUs are often hard to find. They can be very lengthy and difficult to follow. So staff tend to rely on habit or peer training instead of referencing the most recent version. This can lead to situations such as variations in contact time, temperature, dilution, or handling, all of which can compromise the process. This can bring risks which include potential device failure, survey findings, or voided warranties. From a compliance perspective, surveyors cite this requirement under IC 040101 and LD 040309, which hold leadership responsible for ensuring that processes are based on validated science and manufacturer standards. In summary, IFUs specify how a product or device should be used safely and effectively, and following them is not optional. So let's look at some struggles that we face in consistently meeting IFU expectations and strategies that make adherence practical across your organization. A little bit of background. When surveyors cite IFU noncompliance, it is rarely due to lack of intent. It's usually because of accessibility and workflow. The first struggle is access. IFUs are often stored in binders. They may be in emails as a PDF, or they may be in vendor portals. When staff can't find the correct version, they tend to default to memory. So the strategy here is to create a centralized, searchable IFU library or repository, if you will. Make it digital if possible. Include version controls and also vendor contact links. Number 2 is workflow conflict. IFU, and this is IFU conflicts with workflow or staffing. One example of this might be a required contact time that's longer than a room turnover window allows, for example. The strategy here is identify where the risks occur and whether changes in your workflow, staffing, or equipment are needed to stay compliant. Something like conducting a failure mode and effects analysis process can be helpful to assist here. The third issue is outdated or conflicting policies. IFUs can change over time, and sometimes policies don't keep up. So the strategy is to create a time frame for reviewing IFUs. An IFU review calendar is a great idea. Have strong vendor relationships. Pay close attention to packaging and or IFU changes, and this will also help assist end users in changes and updates. There can also be a knowledge gap that creates limited awareness. Staff may understand the process or how to use a product, but not necessarily the why. So include IFU expectations into your education plan and use tracers or spot checks. And this might be something as simple as when you're in front of a staff member, have them show you the IFU for the product. It helps keep this process practical as well as measurable. Finally, leadership accountability is essential. IFU isn't just a technical issue. It's linked to infection control and environment of care oversight. When tracked and discussed at the leadership level, compliance improves significantly. By focusing on access, workflow, and accountability, organizations can smoothly integrate IFU adherence into daily routines instead of rushing to meet requirements during surveys. Next, we're going to look at another Something Blue challenge, and that's competing priorities, which can weaken even the strongest infection control programs. Infection prevention often competes with other things on a hospital's agenda. Some examples might be staffing shortages, patient satisfaction and throughput, or readmission metrics. Even the most effective infection control programs can lose momentum when priorities shift. The expectation is that infection prevention is a daily operational focus across all disciplines, making infection control a shared responsibility. Resources are needed, and leadership support plays a crucial role. If there is no visibility at the executive level, infection prevention can easily fall off the radar as focus shifts towards other priorities. The reality is that competing demands can make even high-risk practices seem secondary to more visible operational pressures. As we mentioned earlier, infection control tends to be seen as an add-on. Things like hand hygiene, PPE, environmental cleaning, and IFU adherence all compete for time in an already stretched environment. The impact of competing priorities is clear. It results in preventable infections, unrecognized process failures, and survey findings that leadership did not anticipate. So rebuild your focus by making infection prevention a natural and important part of your daily routines, included in discussions, huddles, and improvement plans, as opposed to having it be another initiative competing for attention. Recognizing that competing priorities can weaken infection prevention efforts, let's take a look at how to manage them strategically as opposed to reactively. Infection prevention shares space with many other organizational goals. People and systems have a limited capacity, and constantly shifting focus causes drift. So, what's the strategy for managing competing priorities? Begin by integrating infection prevention goals into broader organizational dashboards and performance reviews as opposed to being a separate report. This creates visibility and shared responsibility housewide. Remember, infection prevention is everyone's responsibility. And if you integrate infection prevention into your organization's core structure, this will maintain visibility. Next, align infection prevention efforts within existing committees such as quality, environment of care, or patient safety, so it becomes part of our operational language as opposed to being an add-on. Third, maintain leadership visibility. Regular rounding and feedback loops connect infection prevention to patient outcomes and help staff see it as a safety function, not just a regulatory obligation. Finally, streamline your initiatives instead of launching multiple infection prevention campaigns. A couple examples of how you might do this is hand hygiene supports CLABSI reduction, or cleaning supports better patient outcomes. When infection prevention is embedded into how your organization functions, it stops competing with other priorities. So let's conclude. I want to unify all the points. Something old reminded us that the basics, hand hygiene, PPE, and cleaning, are the foundation of infection prevention. Something new showed how evolving technology, high-level disinfection progress, and updated standards move us forward, but only if they improve reliability. Something borrowed revealed how checklists, redundancy, and debriefs can transform outcomes and share safety responsibility. Something blue reminded us that competing priorities and drift are inevitable unless infection prevention remains visible, valued, and integrated. So thank you so much for attending this presentation. We do have references on the slide, and I'm going to hand it back to Cheryl for the wrap up.
All right. Thank you, Jane. Thank you, Sharon. And thank you, everyone, for your attention during this webinar. We do have a QR code for our Metrex survey up on the screen right now. I'll also put the link in the chat available to you all. We had a few Q&A questions come in, so we'll have Jane and Sharon address those. I'll read them out and have them comment. If you have additional questions, please feel free to put them in the Q&A box. If we do not have time to address all the questions, we will be able to reach out to you, get you an answer, as long as you're not submitting a question anonymously, because then we don't know how to contact you. But let me go ahead and put the link in the chat so you can copy and paste it to your browser if you don't want to scan the QR code. Please complete the survey by next Friday. This is for your 1 CE. And if you have any issues, please contact me at metrexmarketing@metrex.com. The survey is for our benefit to hear your experiences with infection prevention, and then our survey will redirect you to an evaluation form at our CE providers portal. If you've never done a Metrex Prof Ed before, you may need to create a new account at our CE providers portal. However, it is free of charge, and you can download all of your CE certificates from there. All right, so with that being said, let's go ahead and take a look at the Q&A. First question that came in is from Kathy. She says, we have a wellness center used by the public. The public wipe the equipment off with cloth disinfectant. They use the same cloth when wiping down the various equipment used. Should they be using a different cloth for each piece of equipment?
This is Sharon. I'll take that one. Well, remember we talked about how reusing wipes simply spreads contamination rather than removes it. So the same theory applies here. If they're using the same cloth on every piece of equipment, then theoretically they're spreading contamination. So if possible, we always like to go with, single wipe, single use, kind of a one and done type of approach. So I hope that answers your question.
Thank you, Sharon.
You're welcome.
Jeanette asks, checklist built into EMR. Can you suggest a way that this will be usable by a single person? Isn't the person performing the procedure by memory and then documenting in the EMR after the procedure is completed?
Jane, you want to take that, or you want, would you like me to answer that? And let's both answer it.
Yeah, I was trying to think of an example here. And if you have something that's top of mind, Sharon?
I don't, but I think Jeanette is right. The person performing the procedure by memory and then documenting in the EMR after the procedure is completed. There's got to be some way where the checklist is being used during the procedure, because right, isn't the idea of the checklist to make sure we don't miss any steps?
That's exactly what I was thinking. Yep. Just reading through the question here.
Yep.
Um,
So checklist built into EMR, that's, I think it's good to have it there so that the checklist that you use can be compared to make sure they're the same checklist. But that's a great question, Jeanette.
it is. It
I'm a little
is.
stumped on how to combine the two.
Yeah, and I wonder if there's a specific process or procedure that you're asking about. That
So
would be
Jeanette,
also good to know.
what we'll do is we'll get back to you with an actual answer. How about that? So if you could put your information in the Metrex marketing, Metrex at Metrex marketing at metrex.com, we will make sure we get back to you with an actual answer to the best of our ability.
All right. Next question is from Trey. What about IFUs that show you should clean with a certain chemical, but does not have an option for spores? This would make it difficult for C. diff patients.
Yeah, Trey, this is a conundrum that happens all the time. We're all about patient safety, but the IFU says use a certain chemical. Sometimes I've heard, and maybe I shouldn't even mention this, that people, if a chemical isn't mentioned, they might use that. But we do know that for C. diff patients, we need to use something that's a sporicidal product. So this is another tough one. We can get back to you with a more complete answer. I'm looking from the moderator. Some organizations use this with HLD reprocessing. There are systems that are built in. So we'll get back to you with more information on that to maybe help you manage this type of situation. Okay.
Thank you. And a question from Taylor. Our EVS team uses bottled disinfectants currently with microfiber cloths. Some recent studies I have seen suggest that disposable wipes can be used more appropriately by staff and have a better outcome. What are your thoughts? Should we be using more wipes versus bottles cloths? Thank you.
So this is Sharon again. This is just an opinion, okay? Disposable wipes should be used more appropriately by staff and have a better outcome. Again, we want to make sure that we're not using the same microfiber cloth to clean multiple surfaces. And sometimes that's hard to do. And that's why a lot of times EVS does that kind of like four-way fold of a microfiber cloth so that each part of the cloth only touches a surface one time. So if you're doing that, you should have a good outcome. But I think that can be tricky unless the cloth has different colors on it so you know which side you flipped. I'm for take a wipe, use it, you know you've used it, and get rid of it and take another wipe. Jane, what's your opinion?
I agree with you, Sharon, 100%. Fresh wipe every time. Yep.
Yeah. And that's not just to sell more wipes. It's just to prevent the spread of contamination by using the same wipe over multiple surfaces.
Mm-hmm.
All right, and then we'll just do one more question. And if anyone else has additional questions, again, please feel free to email me. I'll get them to Jane and Sharon. We'll get you some assistance. We'll get you an answer. We love to help our IPs in the community. So last question we'll answer live here. Marcelisa says, other tips in leadership engagement and buy with new initiatives? Also, IP rounding with hand hygiene audits have very low engagement.
Well, hand hygiene has always been a struggle. You know, we've done all kinds of fun things, contests, videos, screensavers, this, that, and the other thing, and we still hover around 50%. It's a tough one. Sometimes when I've been rounding on the floor and I'm trying to encourage better hand hygiene, I'll kind of redirect it to how would you feel if the caregiver caring for your loved one didn't perform hand hygiene? And it's not to make that person feel bad, but it's to make them understand the importance of it in preventing transmissions. There's a lot of information out there about how to get higher engagement. It's just that until we make hand hygiene something that's like breathing, we are going to continue to struggle with this. As long as your leadership is fully engaged in providing you with things you can do to increase hand hygiene, that's great. Jane, what do you think?
I think you covered it, Sharon.
Okay.
No, I like the comment about thinking about your loved one. How would you feel if you saw someone? And I have seen the same things when I've been in the hospital recently with my mom and I see someone not wash their hands. It's a cringeworthy moment for sure.
Yep, absolutely. So we've got an anonymous one here, huh? Cheryl, national
Oh
record.
yes, if you've submitted anonymous questions, we have no way to reach out to you with the answer. But I'll if people want to stick around for just another minute, I'll read this one anonymous question that came out here. Are there any national recommendations that spray disinfecting solutions should be sprayed directly onto the microfiber cloth versus the surface to be cleaned? This is in regards to EVS staff or direct care staff cleaning equipment.
So this is Sharon. Off the top of my head, I don't know if there are any national recommendations, but I do know as an IP, spraying directly on a surface can aerosolize what's on the surface. That's why we always encourage people to spray the cloth first. And it just seems to make more sense to me. If there's a national recommendation, I could try to look and find one, but off the top of my head, I don't know. I'm sorry.
Well, we appreciate all of your insights, both of you, Jane, Sharon. Thank you so much for spending your time with us, and thank you to the entire audience for spending a little bit of your busy day with us. I hope you have a good rest of your day, and we'll reach out. Please feel free to reach out with any questions, any comments, any feedback. Hope to hear from you soon. Thank you all.
Thanks, everyone.
Thanks, everybody.
Have a great day and a great weekend.